to Dr. Antonio and team for the invitation. I've actually compressed 2 talks into one, so I'm sorry if a little bit, maybe a little disjointed. I think Charles Darwin's statement holds true, and definitely, if we are to survive, we need to change. And I think change we have in the transplant immunology and the transplant arena. And from a CDC of many decades ago, we have moved on to many other platforms of testing. This fear of this nightmare also, I think you will agree, has changed. And today, we look at a different scenario. We look at 5 years, 10 years, 15 years follow-up to see, is the patient doing well? If not, why not? So whether it's HLA matching or whether it's the presence or absence of antibody, we still find that there's a drop in graft survival. And that is something that we need to focus on, because when somebody has actually invested in a transplant, I think what we really want is longevity of the graft. So very briefly, we know that the CDC is a complete contraindication to transplant, provided we demonstrate that it is an actual true anti-HLA antibody. All other platforms we know confers a greater risk to transplant. This is the flow, and we have here a graph which clearly displays depending on whether the donor-recipient cross-match is flow positive or negative. So the bead-based assays came in a really big way. And slowly, the single antigen bead per se really became the star of the show. Whether it was a nephrologist or the transplant immunologist or the surgeon, a lot of people started asking for this test, which at one point was pretty unaffordable. So against this background, before I get into actual algorithms, I will just talk briefly about the single antigen bead assay and some of the things that can confound its interpretation. Very quickly, it proved its worth, and if you had a DSA based on an SAB, they did worse, particularly in the long term. So it's against this background that we will be doing the next few minutes. So the SAB was sort of quoted as the ultimate solution, the star of the show, extremely sensitive, extremely specific, and as a gold standard. And its clinical applicability was well demonstrated, particularly in the long term. But there are some things that we have to remember when we do an SAB. The SAB is very expensive, as we all know, and therefore we tend to cost cut. But it's important that our controls are actually looked at extremely carefully. If our controls do not work, we just jolly well repeat the test. There's no question about it. You can have high, low, negative, positive controls which are not off. You can have extremely high negative controls, but whatever it is, an interpretation cannot be done unless your controls are worked. The second challenge is the challenge of cutoffs. I'm sure if you ask all of us who used SABs, one will use 500, one will use 1,500, another 1,000. And therefore, each lab finally sets its own cutoff. And this is a paper where they actually looked retrospectively at almost 6,000 transplants and then set their cutoff of 500. They looked at 1-year and 8-year graft survival. And then based on the differences they saw between those who had good graft outcome versus worse, they actually set it at 500. So our lab, we use 750 to 1,500 as a borderline positivity and anything more than 1,500. But a lot of labs actually use 1,500, 1,000. So if you have to interpret an SAB, ideally you should have a high resolution typing. So you can see here that the O205 is a mismatched antigen and that there's a clear DSA to it. But if we have an intermediate resolution typing, let's say you do a Luminex based and it gives you a string of alleles. Now in that string of alleles, one will be there as the most probable. So in the absence of that, very often that can be used. And we've sort of looked at about 500 typings of those who had both intermediate and the high resolution typing. And in all, barring 2 patients, we actually had identical results. So it's a good substitute in case you do not have an NGS-based HLA typing. Now, when you actually look at SAB, one of the things that gets quoted is the MFI. And does the MFI actually impact on clinical outcome? So here in this study, they said less than 5,000, 5 to 10, and greater than 10, there was actually a statistically significant difference. But here, in this other study, it said that if you had an MFI less than 1,500 versus the rest of the crowd, it made a difference. But between 3, 5, 7,000, it really did not impact. So you can see that there's a lot of variability in the way clinical applicability has been quoted. So it has to be remembered also that the SAB is not a quantitative assay. It is a semi-quantitative, more qualitative. So we know that we have an antibody against a donor-specific antigen, but we cannot actually measure and say this is its quantity. MFI thresholds can vary across kits. You use different lots, it can vary. The other thing is that you can have variable antigen density across beads. So particularly for C and DP loci, generally you can get very high MFIs, but they do not translate to clinical applicability. It's just related to the variability in the density of the antigens on the bead. So therefore, you have to interpret it extremely carefully. An attempt was made to try and quantify the MFI, but actually, if you need to quantify, the only way is to do a titer. We cannot use an SAB output and say that it's a quantitative assay. The next problem relates to the conformational changes. You all know that it's a recombinant antigen which is actually stuck onto a bead, and therefore you can have a lot of changes. This is a patient who had a donor with whom he was CDC and flow negative, but had a very high DQB1 antigen antibody. And it was like 9,000, 10,000, that kind of a range, which you definitely would expect to be flow positive. We repeated, we did it in dilutions, wondering whether it was a prozone effect, and then tested him against multiple DQB103 allelic matched other donors. But he was consistently negative on flow. Other patients with DQB103 antibodies were showing flow positivity. So we presumed that this was probably due to denatured antigens. So that is something we have to keep in mind, that we can have antibodies to denatured or cryptic epitopes of HLA antigens, and these can give us false positives, and it has to be dealt with carefully. Now, there's a way of actually differentiating. So, for example, if you have a HLA-specific antibody, you can get a clear answer here. The red ones have all bound. Now, the black ones are the denatured antigens. Now, you can have antigens. If all the antigens are denatured, if you have specific antibodies, you will end up getting a false negative. Now, on the other hand, if you have antibodies to these denatured antigens, you will end up getting a false positive. So it's important to remember that an SAB, whatever gold standard it may be, comes with a share of problems, and we have to correlate it along with other platforms. So this was a publication of that case that we saw. The other thing is, based on therapeutics, if you've been given IVIG, if you have high complement levels, these again can interfere with it. One question that often comes up is it prone to the prozone effect? We haven't found it in the kit that we use, but I know that some can be prone to prozone. So if it doesn't correlate with the flow, please make sure that you dilute it out. Now, if we really want to get rid of our non-specific antibodies, one of the things that we can use is called the ACTS protocol. So we take the donor's lymphocytes, the donor lymphocytes, and actually adsorb the patient's serum onto it. So only the true antibodies will adsorb on. Anything to non-specific positivity will not adsorb on. You then elute out that antibody, and when you run a single antigen bead assay, then you will get an actually more accurate set of results. And these usually will always correlate. So this helps. And all these pitfalls of the SAB, it is important that we are aware of, and it actually translates in the consensus document of 2013 which came out, which talks about all the ups and downs of the SAB. Now, this is a patient who came for transplant with a B4006 who was mismatched. And you can see here that you have a CDC negative, but a flow positive cross-match. Now, always look to see if all your mismatches are represented. It's a huge problem. I think it's being fixed in the extended panel, which is coming up, but it's important to know that this can be an issue. Now, one way of getting over this is to see whether other antigens of the same antigenic family are positive. So you can see here that you have a B4001, which is positive, and the red arrow points to the eplet, that epitope that has been represented on the bead. Okay. Now, the other allele, 4002, is also positive, again with the same epitope. Now, if you look in the epitope registry, you can see that 4001, 4002, 4006, all of them share that same epitope. And when you look at the epitope registry, it also tells you that this in red is an actual, it's an exposed eplet. So when you see the entire gamut, as Dr. Feroz mentioned, it tells you what the hidden epitopes are, what the moderately exposed epitopes are, and the ones in red are the clearly exposed and possibly higher, those with higher immunogenicity. So this definitely is a significant antibody, and there probably is a DSA. Okay. So it's important to keep that in mind when we actually look at this. The lack of representation of these and the lack of local Indian data also actually prevents us from doing a calculated PRA. So it is important that we put our data together so that our PRAs convert to a CPRA, which is actually the more important one. Now you can add some more value to an SAB by checking if these antigens actually bind complement. So you have C1q and you have C3d, and there's a lot of literature to say that if it binds complement, then the outcomes are worse. So while we look at this virtual cross-match, it's important to remember that it's not all hunky-dory. You can have problems, and that you use it in an appropriate way. So here you have two patients, both who are very similar in terms of matching, one with a slight, a weak B-cell positivity, and an MFI showing you and the SAB showing you a DSA. So clearly that may be a no-no. But if you take the patient on the green side, you have a DSA of 3000, which has not translated to a flow positivity. So definitely it raises a warning. So I think the SAB, to be fair to it, while it may not be absolute in terms of converting to a yes, I will transplant, no, I won't transplant, definitely gives you a warning of risk, and it's important to keep this in mind. So when we move into starting the thought of algorithms or change, they say that, if it's done properly, then you get a really pretty butterfly out of your pupa. But otherwise, what you get is a really fast caterpillar, which we don't want. And I think the interpretation and use of the SAB is one such, where we have to be really, really careful that we don't define everything in just black and white, and actually look to make sure that our interpretation is right. One of the major lessons that I learned from one of our mentors, to many of us in this room, whom we lost, unfortunately, very recently, Professor Claus, was that when discussing these antibodies on very sensitive platforms, he said, please remember that these tools are not to prevent a potentially safe transplant. We should always use them to facilitate a potentially safe transplant. And that's something that we have to keep in mind. And the 𝐸Sort actually gives us a really nice way of the way these different platforms compare to each other and the element of risk that they throw in. And definitely an antibody increases memory, whether it's humoral or cellular. And it is important to remember that when we use it to formulate our algorithms. So how have different organizations actually looked at algorithms? This is a British group which insists that you do a high resolution HLA typing, 11 loci, and antibody testing definitely virtual, and if it's complicated either from a clinical viewpoint or from an antibody viewpoint, then you do a physical cross-match. Now, a physical cross-match should be able to distinguish T and B cells, and it must be able to detect HLA IgG antibodies. Now, therefore, it should include a DTT, because if you suspect it, you should be able to get rid of the IgM. Now, they also go on to say that if you find a B-cell cross-match which is positive, but a single antigen bead which does not show you a DSA, it is important to exclude a HNA3 antibody, because that is one antibody which can present as a B-cell positive cross-match and cause problems during transplant. And if that is proven to be absent, then you can actually go ahead. But in our setting, representation of antigens, mismatched antigens, is something that we should take into consideration. The KDIGO guidelines are very similar, except that they go on to say that if there's an antibody, please look for a patient-donor combination where you can avoid using a patient with antibodies to that specific donor. And the consensus guidelines insist that you do a solid phase assay plus or minus a cellular assay based on national guidelines. That is, those are specific to that place. But irrespective of all these guidelines and literature, I think there's a huge elephant in the room which we don't talk about, and that is within the context of our country. Now, in the context of our country, cost plays a major role, and this is the ascending cost of the different tests that we do. Also, we're challenged by such basic things like poverty, GDP, lack of employment, and in that context of things, transplantation really sort of takes a backward space, back burner status. The huge divide between rich and poor and affordability also raises ethical questions as to where do you pitch your testing algorithms. But the bottom line is that transplant is here to stay. And how do we make it more affordable and more safe for our patients is something that we cannot run away from. Because finally, when we talk about cost saving, in the long run, if he's going to have lesser rejection episodes, longer graft longevity, it is a financial saving, and therefore it has to be put into perspective. The other issue is that we are in a country where we have patients dying of sepsis maybe, but with a functioning graft. Too much immunosuppression comes with its share of problems in our country. And therefore, if you can give something which is immunologically more compatible, definitely it's going to help. So how have some of the allocation systems actually worked their way around? Now, the new 𝐔𝐬𝐧𝐥𝐵, as they called it, in 2014, worked for almost 10 years to come up with this new allocation system. And they said that it will result in 9,000 additional life years, either in terms of the number of transplants or in terms of number of life years annually by this revised way of allocation. A beautiful study from Sweden actually looked at patients' outcome, not in terms of how long they survived or not in terms of how long the graft survived, but in terms of how many of them actually went back to work and got back into employment and the labor market. Now, our patients do a real tightrope walk when they come for transplant financially. And they're not doing it to break a Guinness record, they're actually doing it for a living. And therefore, I'm convinced that we should give them the best chance at graft longevity. And therefore, with these different platforms that we have, what can we actually do? The first thing is to take a really good history to stratify immunological risk. The second is to do the HLA typing to the best level of resolution we can. And then choose a combination of antibody testing platforms to assess graft risk. And most of this should be, of course, evidence-based. So how do we assess immunological risk? Of course, the standard transfusion, transplant, pregnancies. But if you look at the STAR guidelines of 2017, if somebody coughs, they move into a high risk because any level of inflammation pushes you into a higher risk category. So basically now, whether they're higher or lower risk, the same battery of tests continue in the institution where we work in. So this is the standard thing which has been talked about from morning to evening. So a good high resolution typing is a must for patient and donor in a live related setting. Right now we're doing a 6 locus typing, but in the process of moving to 11 locus, and it's just had its share of problems. But just look at this patient donor pair. The top one is the same patient donor pair at low resolution, but the moment you make it high resolution, actually they change from a 10 by 10 to a 5 by 10 in this instance. So it's important that we have a high resolution typing, which will give us a better idea of how well they're matched. So this is our algorithm. Following assessment of historical risk, we go in for a high resolution typing for both patient and donor. Both patients and donor, they then have a CDC and a flow. And if the CDC and flow are negative, with the same serum, we do a single antigen bead assay. Now, if the CDC shows you an IgM antibody, maybe I'm extremely old-fashioned, but we wait for 2 weeks, give it time to class switch, and then do the SAB at that time after making sure that it's either remaining an IgM or whether it has changed. So if the transplant is more than 6 months later, we repeat an SAB, or if there's been a sensitizing event between the previous SAB and transplant, then an SAB gets repeated again. The post-transplant testing is really based on a need. It's need-based, and we do not have a fixed protocol for going for post-transplant monitoring. But we do use donor lysate. We store it because it's very difficult to do a flow later, post-transplant access, and we've really failed in our liquid nitrogen storage of lymphocytes. It's been very difficult. So we use a lysate stored for a backup lysate crossmatch if required later. So essentially, this is the same thing in another format. So suppose the CDC actually turns and becomes an IgG. At that point, we will repeat a CDC flow and an SAB to see whether there are antibodies at all other levels or whether this is a non-specific positivity. That correlation has to be done. If it continues to remain an IgM, it's very important that we screen on more sensitive platforms to make sure that there's no lurking IgG. Now, one of the things which has helped us implement SAB across the board has been the half reaction protocol. This was validated in Professor Claus's lab in Leiden in the Netherlands, and this has made a huge difference to the way we've been able to make it more affordable for our patients. Now, if it is a second transplant, we need to be sure that we've always got the typing of the first donor, and these have to be classified as unacceptable. And it's important to look for CREGs to those mismatched antigens as well, because the anamnestic response, if we retransplant with shared alleles, can be a big problem. Now, for a deceased donor, what do? All patients have a high resolution typing done and a single antigen being done anywhere in 3 to 6 month intervals. So at the time of transplant, we do a donor typing on intermediate resolution and also a CDC and a flow. The SAB is repeated only if there's been a sensitizing event or the time interval has been large. So this is the Delhi protocol that Mohit talked about as well, which is an alternate protocol which has been used in our country. And these are this is a protocol which Dr. Noble has actually put together. I think he will discuss it straight as soon as I finish, essentially giving us an outline for what could be followed here using the multiple platforms available. So uh, the next few slides are just to highlight the fact that everybody will not fit into this one-size-fits-all. So there will be exceptions, and how do you handle those? And so therefore, it is important to remember that precision medicine is coming into this arena as well, and it is important from a lab point of view to offer what you can to those who are exceptional. And one of them is the highly sensitized patient. Now, very often, this is a line you hear when you want to introduce a new test or try a new algorithm. You know, it's always been done this way, it's okay. But I think we shouldn't let us put it off and just, you know, plug on trying to get something which may be better for the patient. One question we always ask ourselves is, are we plugging the right hole? When you see somebody who's highly immunized, particularly young males with no other history behind them, it's very important to remember that if we can minimize that, we will save so much heartache. One of the things which has made a huge difference has been the use of leukodepleted products. And this, the moment you see somebody with renal failure now, we just start with leukodepleted products, and this has actually changed the landscape of sensitization in some groups. So when you see somebody who's highly sensitized, it's important to make a list of unacceptable antigens. You can look at epitope reactivity and draw out a list of alleles which also may be non-reactive. So for example, if you see the set of antibodies and you see this epitope there, 144K, now you go into the epitope registry and you see that this epitope 144K is reactive against so many other alleles as well. And therefore, in somebody who's highly sensitized, once you start making antibodies, the tendency to make antibodies is much higher. It's true in the red cell arena, it is true in this arena. And therefore, it is important to look at this and avoid those alleles which sort of share the same applet if possible. So this case is just to show you a patient with 3 potential donors, very similar matched, 7, 8, and 7 matched, all negative for antibodies. But just asking ourselves, are some mismatches more forgiving than others, brings us to the whole concept of the P and the G groups. We know that what actually matters are those in the peptide binding groups. And if the amino acids in that area or the nucleotides in that area are the same, then you know that the compatibility is going to be much more. So if you have 2 different alleles will belong to the same P group or the same G group, then it's a much better match. Also, if you actually put it through the EMMA software, which looks at mismatch loads, here you can see that the mother, who's a 7/12, has almost 20, 30, about 43 mismatches. But in the solvent accessible areas, which is the significant areas, it's 18 and 11. Now, the next donor, who's the father, is a 8/12, but has only 11 and 11 solvent accessible mismatches. And it's interesting to see that you have the same allele, 601 and 603, which you think are very similar, but actually they are significant in the number of mismatches that are even solvent accessible. So therefore, you actually come up with donors who are very similar in terms of a match, 7/12, 8/12, 7/12, but who have quite a difference in terms of their number of solvent accessible mismatches and therefore may be more immunogenic than others. And we find that the P and the G groups actually correspond to this finding. So when you find a mismatch, it's always good to look at the P and the G groups. So we did a small study where we looked at epitope and antigen amino acid mismatches. This is one of our PGs who just finished this. And we looked at more than 200 patients using the EMMA. And we found that the total epitope mismatch load really did not vary between patients and controls. The patients were the ones who had biopsy-proven rejections.
You hear me now? Good.
When we looked at individual classes, the class 2 mismatch load actually seemed to reach some kind of significance with a p-value of exactly 0.05. Now, we also found that when you looked at different loci, the DQB1, the mismatch load at the DQB1 seemed to be statistically significant. The other tool that can be used is purge. So when you have a high resolution typing, these are tools which can be used. So it's gone blank.
Can you hear me now correctly? Hello?
Yes. Yes, Dr. Christine, we can hear you. This is Joy Mamin here. Antonio, can you hear me?
Yeah, I hear you. Everything is okay?
Great. Yes,
okay,
I think we're good. Good afternoon. This is Dr. Joy Mamin. I'm speaking from CMC Vellore.
Good afternoon, sir. I'm 𝐤𝐻𝐬𝐧𝐠. I'm from Christ University. Am I audible?
So the next tool that can be used if you have a good high resolution typing is the PERT score. And we did a small study looking at about 122 patients who had undergone transplant. And we found that the class 2 derived PERT scores, whether they were DR derived or DQ derived, actually seemed to impact. And that cases had higher PERT scores if they were class 2 derived. So this is a patient-donor pair. The first one is a 1/10 match and the next one is a 3/10 match. So you can see the mismatches in red are the ones which are not represented on the single antigen bead assay. So when we did antibody testing, the second donor was weak flow T and B cell positive. The other one was negative, but both of them had a DSA. The first donor had a DSA to a DRB1 and the next to class 1. Now when you look at this, you find that the class 2 derived PERT scores and the class 2 derived PERT scores of donor 1 and 2 are quite different. And so is the epitope mismatch load. And clearly, the donor 2 had both a higher mismatch load of the epitope as well as a PERT score. And that you can see has also correlated with a flow being positive. So while these tools are not set in stone yet, they seem to correlate with our conventional tests that we have. So in the setting of weaker antibodies, they may evolve. And I think more data in this regard will help us tremendously in stratifying risk. Now, this is a young male awaiting second transplant, highly sensitized. And one of the highest MFIs he's had is against the DQB103. Now, he's come for at least 4 deceased donors as the first possible recipient. And he's always failed because he's had such high MFIs. Now, we looked at our data of high resolution typing, and we found that DQB103 was found in almost 1,000 of the 3,000 donors patients and donor pairs that we had actually worked up in our lab. Now, if 1 in 3 is going to be positive, you can see that the chance of him going to get a donor on a deceased donor list, which is local, is going to be extremely tight. So it's good to look at our data to also give some kind of a realistic impression to our patients as to how easy or difficult it is going to be to get a donor if they are highly sensitized. And the last thing is the importance of actually getting our own haplotype data, because some of these associations are very strong. And if we know that some antigens actually coexist and somebody is highly sensitized, then they have a realistic view of where they stand. In the setting of SAB, we know that if we are able to separate out antibodies which bind complement versus not, the outcome data is quite striking. Those which actually bind antibodies do worse. So that is an assay that we're just beginning to look at. Cost is an issue, but if it gives us some worthwhile information in the long run, it may make a big difference. And as Dr. Noble said, unexplained rejections are a huge issue, and non-HLA is a problem. This is just our data, which we did, which we checked out a couple of years ago when we had a whole crop of rejections. And we found that anti-endothelial, not donor-specific, but anti-endothelial antibodies were very high in this cohort. They were all negative for 𝐸𝐾 and angiotensin 1 receptor antibody, but we found this. Whether this actually translates, but it was a flu period, and we didn't know whether that was the source of antibody. But testing it for a routine, for decision-making, has to be very carefully done. So this is something that we have to keep in mind. It's a study which came out in NEJM a few years ago, where you had different levels of sensitized patients. But when you looked at the outcome, those who were transplanted did significantly better than those who were not transplanted, who died on the wait list. So therefore, it's something we need to keep in mind before we blindly refuse a transplant on highly sensitive tests particularly. So I just want to end with a few lessons learned. The first thing is that none of these tests have worked in isolation or will work in isolation. It is important to understand the pros and cons of each test, and finally base it on clinical applicability outcome, particularly long-term outcome. And unless we put this together, it'll be a problem. Now we need to put it together because otherwise we will not be able to give our patients the equity that they truly deserve. It very often means getting out of our comfort zones. I know it's a huge, in our growing up, for the lab to talk to a clinician, we are scared. So it takes a lot to break that barrier and actually get across, but I think that that's where the magic will actually happen. And that's our wonderful nephrology team, without whom I don't think half the work that we do will actually happen. And of course, all the people who work behind the scenes to make these things happen. So in nature, nothing is perfect. And so is it. Everything looks contorted, but everything looks beautiful. And I think it's the same with our tests. None of them are actually perfect, but I think they're beautiful in their own way. So this is my son who did a long 5,000-kilometer cycle ride solo with a tent in hand, and that's him on top of one of the mountains in Norway or somewhere. Oh, no, this was not for that. No, but I asked him, weren't you scared? Because there's nothing around him, and he and a drone, and he told me, Ma, it's just that small bit of fear before you take the first step. You get on top of that and then you continue, and you should never let yourself panic. I put this here because it reminded me of this, it's the pebble in your shoe, and I found it very akin to us fighting for things when you need to get things done in this transplant arena. Before we got a molecular lab, it was such an uphill task, and sometimes you feel like giving up. So I think the important thing is to remember that whatever we are sort of working towards, they're just small pebbles in our shoe, and we just need to keep moving. Thank you.
Thank you, ma'am. That was a wonderful talk. My question will...
The DNA... No, the antigen gets denatured in the assay. Yeah, so when the recombinant antigen gets stuck, they say that it is a very practical problem that you can have. So it's not even lot-to-lot consistent. So you can have some denaturation that happens. So if you have an antibody which is non-specific, which happens to bind to one of those denatured antigens, then you end up with a flow which is negative, because with the donor cell it doesn't react with the native antigens, but with the denatured antigen it reacts and gives you a very high value. So that putting together is very important.
Madam, irrespective of immunological risk, you have to do single antigen bead test, all patients. What about HLA typing for all, means A, B, C, DR, DP, all this should be done for all patients? Or?
So it's actually, it works out to almost the same cost, whether you do an ABC, DR, DQ, DP on an NGS, or you do an additional, the DQA1, DPB1. Now we're planning to go into 11 because maybe a difference of about $1,500 to $2,000. So in the larger scheme of things, if it's going to give us better information and better information to follow up post-transplant, we would rather shift to that. But ABC, DR, DQ, DP gives us a good sense because DQ-A1 antibodies, DP-A1 antibodies, I mean, we don't see so frequently, but.
Any more questions from the floor? Since we shall wind it up, thank you, ma'am. Thanks a lot.
Thank you, ma'am, for the enlightening talk. I invite Dr. Anil Hantu to present memento to Dr. Dolly Daniel, Dr. Mohammad Iqbal, and Dr. Sajeev Kumar.